This is the PEDro World-Wide Journal Club for the article by Alison Huang and colleagues entitled Efficacy of a Therapeutic Pelvic Yoga Program versus a Physical Conditioning Program on Urinary Incontinence in Women, a randomized trial, published in the Annals of Internal Medicine in 2024. 1 in 3 women will experience urinary incontinence in their lifetime. Urinary incontinence can have physical health consequences, such as skin irritation and infections, psychological and emotional consequences, such as depression and anxiety, social isolation and withdrawal, and potentially the exacerbation of other health conditions, such as weight gain due to reduced activity. There are multiple types of urinary incontinence, which include stress incontinence, which is the involuntary leakage of urine that occurs with increased intra-abdominal pressure, such as exertion or straining, urgency incontinence, which is due to muscle overactivity or contractions. The contractions may be caused by irritation or loss of neurological control. Mixed type incontinence, which is a combination of stress and urgency incontinence. Overflow incontinence, which is the leakage of urine due to an overdistended bladder. And functional incontinence, which is involuntary leakage of urine due to environmental or physical barriers preventing people from getting to the bathroom on time. Nearly 50% of women receive no treatment for urinary incontinence. The reasons are multifaceted and include accessibility of treatment, belief that urinary incontinence is not a medical priority, lack of knowledge about treatment options, and social and psychological barriers such as embarrassment, stigma, and fear of judgment. Specific pelvic floor exercises and bladder retraining can be effective, but are often difficult to perform alone without a healthcare practitioner. Medical management, such as pharmacological treatments, can alleviate symptoms, but often have side effects and are subsequently discontinued. Yoga is a treatment that is currently used by women with urinary incontinence. It potentially improves body awareness, pelvic floor strengthening, general muscle conditioning, and muscle control around the pelvic floor. Although it's frequently used, yoga may not be effective and may have side effects. Given this, the effectiveness of yoga needs to be evaluated in a high-quality randomized trial. The aim of this trial was to determine if group-based pelvic yoga is superior to non-specific physical conditioning for improving urinary incontinence frequency in middle-aged and older women with urinary incontinence. This study was pre-registered in clinicaltrials.gov. Participants were recruited from the communities surrounding 3 Northern California sites by personnel at the University of California, San Francisco, or Stanford University. Inclusion criteria were women above 45 years old with daily urgency, stress, or mixed urinary incontinence for greater than or equal to 3 months. Participants were able to walk on level ground for 200 to 300 meters. The exclusion criteria were participants that had not participated in yoga, muscle conditioning activities, or pharmacological treatment in the last month and had not received behavioral, invasive treatment, or surgeries in the last 3 months. People with recurrent urinary tract infections or people currently or recently pregnant were also excluded. There are a number of other inclusion-exclusion criteria which can be viewed in the article and supplementary material. Participants meeting the inclusion-exclusion criteria were randomized to one of the 2 treatment groups in a 1-to-1 ratio. Randomization was performed using permuted blocks of 2 to 4 and stratified for urinary incontinence type and treatment site. Allocation was concealed with an independent statistician dealing with randomization. Overall, 240 people were randomized, with 121 allocated to the pelvic yoga group and 119 allocated to the non-specific physical conditioning group. Pelvic yoga program and physical conditioning program were both 90-minute sessions 2 times a week for 12 weeks. They were group sessions that were face-to-face until March 2020, when they switched to online classes because of COVID-19. For more details on both interventions, refer to the article and supplementary material. In the pelvic yoga program, during the session, participants performed 16 hatha yoga postures. These postures were selected by yoga consultants due to their likely improvement that they would provide in pelvic function. Sessions were delivered by an experienced yoga instructor. The non-specific physical conditioning program, during the session, classes involved non-specific stretching and strengthening exercises. These exercises avoided engaging the pelvic floor. These were delivered by personal trainers or physical therapists. Participants in both groups were asked to practice at home for 1 hour per week. In addition, participants in both groups were provided an information sheet for first-line behavioral strategies for urinary incontinence. Given the nature of the intervention, participants and therapists could not be blinded. However, there was an attempt to manage patient treatment expectations by telling the patients that the study involved two types of low-impact physical interventions, with neither yet known to be effective for urinary incontinence. At baseline 6 weeks and 12 weeks, participants completed a 3-day voiding diary indicating the number of times they leaked and the type of leakage. This is a valid and reliable way to monitor urinary incontinence. The primary endpoint was the number of leakage episodes per day at 12 weeks. Secondary outcomes were the number of episodes per day or night for stress-type urinary incontinence, urgency-type urinary incontinence, nighttime urinary incontinence, and daytime urinary incontinence. Adverse events were recorded and were defined as any negative changes in health at each follow-up time point. Between group differences of the change scores from baseline to 12 weeks between the pelvic group and the non-specific physical conditioning group was the primary comparison. Given the primary outcome was reported by the patient, the assessors, which in this case would be the patient, weren't blinded, although all other key trial personnel were blinded. Baseline characteristics were similar between groups, so groups have been combined for this presentation. The mean age was 60 years old, ranged from 45 to 90. The type of incontinence was urgency or urgency predominant in 65% of participants, or stress predominant in 39% of participants. Participants had approximately 3.4, standard deviation 2.2, incontinence episodes per day. The gynecological history was similar, with 84% of participants being postmenopausal, 27% being nulliparous, and 17% having a history of hysterectomy. Note that race, education, and the number and type of self-reported health conditions were also similar between groups. At 12 weeks, 106 participants completed the pelvic yoga program, and 113 completed the non-specific physical conditioning program. This makes the loss to follow-up as 9%, which is acceptable. For the primary outcome, the article mentioned a clinically worthwhile effect, but did not specify an exact number. Other pelvic floor studies have cited a reduction ranging from 1 to 2 episodes per day as being clinically meaningful. For the purpose of interpretation, we'll take the smallest clinically worthwhile effect as 1 urinary incontinence episode. The mean difference was minus 0.3 episodes per day, with 95% confidence intervals spanning minus 0.7 to 0 episodes. This means the smallest clinically worthwhile effect was not met, and the pelvic yoga program was trivially beneficial, had no effect, or was trivially harmful when compared to a non-specific physical conditioning program. To the secondary outcomes, for urgency incontinence, the mean difference was minus 0.3 episodes per day, with 95% confidence interval spanning minus 0.5 to 0 episodes. For stress incontinence, the mean difference was minus 0.1 episodes per day, with 95% confidence interval spanning minus 0.3 to 0.2 episodes. For nighttime incontinence, the mean difference was minus 0.1 episodes per day, with 95% confidence interval spanning minus 0.1 to 0 episodes. And for daytime incontinence, the mean difference was minus 0.2 episodes per day, with 95% confidence intervals spanning minus 0.6 to 0.1 episodes. For all secondary outcomes, we can see that the mean difference and 95% confidence intervals are below the smallest clinically worthwhile effect, and that the pelvic yoga program was trivially beneficial, had no effect, or was trivially harmful when compared to a non-specific physical conditioning program. The article mentions some adverse events. 45 adverse events from 26 people in the pelvic yoga program group, and 47 adverse events from 35 people in the non-specific physical conditioning program group. During the study period, adverse events were collected, but not all of these were related to the treatment. Although one serious adverse event was documented, the author stated that this was not related to participation in the study. Other non-serious adverse events included musculoskeletal and connective tissue disorders, infections, and GI disorders. Other minor adverse events were also recorded. All adverse events were spread evenly between groups. So, in conclusion, a 12-week pelvic yoga program was not superior to a non-specific physical conditioning program in reducing urinary incontinence in middle to older age women with urinary incontinence. In addition, the effects were not clinically meaningful.